Pas grave. Il faut qu'elle écoute. C'est coupé? Non, pour rien.
Good evening, doctors. I think we can start now. Firstly, my name is Abhinav Samadia, and I'm working as country manager for Hetero Labs. I myself, I'm a pharmacist. I've done my master's in pharmacology, and I've been in Kenya for last 7 years. Just to brief you about our company, Hetero Labs, one of the leading vertically integrated pharmaceutical company, manufacturing-based pharmaceutical company from India. And as I said, vertically integrated pharmaceutical company from India. It means we manufacture from raw material to finished formulation. And we actually specialize in ARV segment, and we are also into different specialties. I feel proud to inform all of you that almost 40% of the global requirement of ARV is catered by Hetero. And in Kenya, we proudly claim that every second HIV patient is on Hetero medicine. We have almost completed 32 years, and we are existing in almost we are well spread across the globe. We have almost 5 manufacturing facilities across the globe. Just want to tell you about the vision of our chairman, Dr. B. Path Saradi Reddy. Our vision is to improve the quality of life of people across the globe, and we continue to deepen our impact, supported by our meaningful R&D, manufacturing excellence, and global collaborative partnerships. At Hetero, we say that we are shaping a healthier world, where we have almost like 32 years of expertise with 36 state-of-art manufacturing facility. We have almost like 300 plus APIs, 100 fixed dose formulation, and we also have Asia is one of the largest manufacturing plant which we have in Visakhapatnam. Also, I would like to thank here 2 associations, Kenya Medical Association and Pharmaceutical Society of Kenya, for giving us this opportunity to discuss one of the novel concept in Kenya, a concept which is well established across the globe, and it is relieving patients of migraine from different parts of the globe, a novel concept. And we have 2 eminent speakers with us today. We have from our Hetero team, Dr. Adarsh Shetty, who heads the medical affairs team of Hetero Labs, emerging markets, with 16 years of experience in pharmacology, clinical research, medical affairs, drug safety, clinical practice, and clinical trials. Dr. Adarsh Shetty has been instrumental in driving the scientific engagement and ensuring that medical insights are seamlessly integrated into our strategies. Dr. Adarsh Shetty has done MBBS and MD in pharmacology from the prestigious Banaras Hindu University and has contributed significantly in advancing our understanding. He has many international and national publications under his name and has authored a book in critical care and has also been actively involved in collaborating with healthcare professionals and stakeholders to bridge the gap between innovation and patient care. In addition to his academic and professional achievements, Dr. Shetty has a keen interest in leveraging the technology to enhance healthcare delivery, and optimizing the patient outcomes. Additionally, he has presented papers at many esteemed national and international conferences, showcasing his expertise and thought leadership on various platforms. I welcome Dr. Shetty and I thank you for giving us a valuable time, sir. Next eminent speaker is Dr. Ravi Srivastav, all the way from the France, who is the brain behind the concept of filmogenic glycerol polymer, who is the discoverer of this technology. Dr. Ravi Srivastav is a French citizen who has done his doctorate in pharmacology and cellular biology from University of Limoges, France. Dr. Ravi Srivastav is currently working as the director for Vitrobio Pharma France. He's currently the president and scientific director of Vitrobio Pharma France. Dr. Ravi, his main achievements are he has almost like 10 national European.
super fiican suubane caafimaadkaaga halo waa ku fiicana alxamdulilah waxay tahay dhaladii codkeeda adiga jarad
Sorry about that. Dr. Ravi is member of European Commission for the Classification and Labeling of Chemical Products. He has been awarded with PEXA Award for Alternative Experimental Methods to Animal Testing. And he has also been awarded with Prince Louis de Polignac Award, which is bestowed by the French Academy of Sciences. Also, he is the recipient of French National Assembly Medal for research contribution. I welcome Dr. Ravi, and I thank him for giving us his valuable time. I'll just like to tell you briefly about the flow of the session. Dr. Adarsh will take us through migraine and the new concepts and the new molecules which have been target molecules which have been identified for management of migraine. Then we'll be having Dr. Ravi, who is going to speak on today's topic, that is mix spray, the revolutionary technology in management of migraine. He's going to tell us about the various clinical studies which they have conducted on the brand. Also, he's going to highlight the target molecule CGRP and how the technology helps in combating migraine. So I'll request Dr. Shetty to please share his presentation and start the session.
Yeah, hi everyone. Just a second.
Welcome, sir.
Yeah. Are my slides visible?
Yes, sir.
Yeah. Okay, I'll be very brief because everyone knows about migraine. I think my introduction has been given by Abhinav without delay. So the flow of my presentation would be the introduction, then the types of migraine, then we'll talk about the pathophysiology, and we'll talk about how the CGRP and the inflammatory markers has a role in migraine, then how it is diagnosed, and what are the various differential diagnoses, and what are the common treatment which is used for migraine, and we'll talk about the gaps in the existing therapy. So this is how the flow will be. So coming to the migraine, I think it's the third most common disease after diabetes and asthma, and it is the second most disabling disease in the world. So obviously the quality of life will be hampered, and if he is a daily wage worker, obviously he cannot go to the office or the work, which will affect the daily earning. So in general, 20% of population would be affected by migraine, and majorly impacted would be
Dr. Adarsh, sorry to
Yeah.
interrupt you. Your slides are not visible, sir.
What about now? What about now? Is it visible now?
No, we can't see your slides.
Just a second.
It's not visible, Ravi, Dr. Adarsh.
Just a second.
Yeah.
So what about now?
Yeah.
Okay.
Yeah, it's now visible.
Okay. So usually it will impact the professional lives because the patient will not go to work and he will be put into isolation because of all the stigma. So coming to the epidemiology or the disease burden, it is one of the studies where they have shown that the Kenya the burden is around 33%. This is the study which was done in the students, college students in the Kenya. Obviously, it is not that 33%, but in the community studies, it has been found that it is around 3 to 7%. That is a bit high. And the 43% usually experience 3 headaches per month. And usually the most triggering factors are physical activity and emotional disturbance. So out of 40 students, the medical attention sought will be having around headache in the last year. The main reasons for not seeking medical advice is self-medication because it is not diagnosed. So obviously they will take the NSAIDs. The problem with this is they may go for chronic migraine. So which is again very difficult to treat, the resistance will be there. So better to diagnose early and get the treatment. So migraines are generally identified as headache. Usually it is unilateral. It can be bilateral also in sometimes. And it is pulsating or throbbing. The duration will last for around 4 to 72 hours. Usually it is preceded by nausea and vomiting. And it is sensitive to light, sound, and smell. And the symptoms are worsened by physical activity. So these are some of the common triggers for migraine. Coming to the gender difference, usually it is more common in women compared to men. I think in the below study, they have found that you can see the graph here. The blue line is the female and the red line is the male. You can see after the age 10 till age 60 or something, the disease in the females are very high. And after, as age passes, both will be same. And also it is genetic, and it also has been found that almost 3 times more common in the families. So there are 2 types of migraine. One is preceded by aura, which have a flickering of lights, and another one is without aura, where you will not have the flickering of lights. It is mostly 80%. So without aura is preceded by fatigue and irritability. Coming to the visual symptoms, in the aura, flickering of lights, there will be a dark spots in front of the eyes. There will be a loss of vision. Coming to the sensory symptoms, there will be a pins and needle sensation in the peripheries, usually in the arms, and the numbness will be there in the arms. And in some cases, there will be having a speech difficulties. So what are the triggers? I think I'll just already mention. It is mostly the sunlight. It can be the salt. It can be the lack of sleep is most common. Strong odor, loud music, sometimes alcohol, skipping meals, and hormonal, and even they call it as 5 Cs: the cheese, chocolate, coffee, cola, and citrus fruits. So these are some of the triggers for migraine. So what is the pathophysiology of this migraine? Previous theory was vascular, which has been debunked now. Previously, it was mentioned that because of the dilatation, headache happens. and the visual symptoms is because of the vasoconstriction. The recent theory right now is cortical spreading depression. Here what happens is the entire brain will be hyperactivated, and the self-propagating wave or the neurons which gets depolarized and which spreads through the brain. So which will activate the trigeminal nerves, which is also called as the cranial nerve 5, which will release substance P, CGRP, and the neurokinins, which in turn lead to inflammation, which in turn lead to vasodilatations. There can be mast cell degranulation and the activation of pain receptors. So this is in general the pathophysiology of the migraine. Just now I mentioned the hypothalamus is stimulated, which will innervate the meninges of the brain, which gets activated, which in turn lead to CGRP activation, and inflammatory markers like interleukin 6 and 12 will be activated. Finally, the pain will be the patient will be having the pain. So what is the diagnostic criteria? This is the diagnostic criteria which is international body has come up with. In this diagnostic criteria, what they tell is it has to be diagnosed migraine because the patient needs to have 5 attacks. The duration has to be 4 to 72 hours, and the characterization of the headache should be unilateral, pulsating, and moderate to severe. Usually, you should have 2 symptoms out of 4, and aggravation by routine activity. And one of the non-headache symptoms should be there, like preceded by nausea or vomiting or photophobia. So these are some of the other diagnostic criteria for aura and chronic migraine, which I will not go through. So usually the key distinctive features for migraine are it is unilateral, and the duration is around 4 to 72 hours. It comes in frequencies which is associated with nausea and vomiting. There will be sensitivity to light, touch, and sound. How it is diagnosed? Usually with all the symptoms which I just mentioned. So you can suspect the migraine, having a unilateral headache, visual aura will be there, family history will be there, and you can take the medical history. You can apply the diagnostic criteria which I just mentioned, and you can examine the patient and do some neuroimaging studies. So these are some of the differential diagnoses. The migraine, cluster headache, and the tension headache. So these are some of the other differential diagnoses which the patient or the physician will get confused. So in the migraine, it is moderate to severe. Usually it is unilateral. You can see in the picture. In the tension headache, it is usually bilateral, which is mild to moderate. And in the cluster headache, it is behind the eyes. You can see the different duration. Usually in the migraine, it is 4 to 72 hours. And in the tension headache, it is almost 30 minutes to 1 week. And in the cluster, it is 15 to 3 hours. The pain can last for up to 3 hours. Coming to the other possible symptoms, as I mentioned before, it is usually preceded by nausea and vomiting and sensitivity to light and touch. Usually in the tension headache, it is usually the tenderness will be there. And also there will be some sensitivity to sound and light. And coming to the cluster, there will be a nasal congestion, facial sweating will be there. And in the migraine, which is more common in women compared to men. And tension also, which is more common in women compared to men, except the cluster. Here, it is more common in men, 3 times more common in men. So usually you have to avoid the triggers. You should have regular sleeping habits. These are mostly people will not follow because these are all very important. And going to the darkened room, which will immediately calm the symptoms, and application of pressure, cold or heat, and acupuncture. So these are some of the things which the patient can do as a non-pharmacological treatment. Usually the treatment is usually acute, preventive, and non-pharmacological. Non-pharmacological I just now mentioned. Coming to the acute treatment, initial treatment is the NSAIDs or the painkillers, ibuprofen or the diclofenac. The second generation use the triptans like sumatriptans, and if it is not pain is not getting better, then you'll combine it with the NSAIDs. The third generation is the Titans or the Japans, also called as CGRPs. So adjunctive therapy is to prevent the vomiting and nausea. We go for prokinetic drugs like domperidone and metoclopramide. So coming to the preventive treatment, usually recommended for greater than 2 days per month, in spite of using the regular treatment. The patient is having the pain, then you should go for a preventive treatment. The first line treatment usually is a CGRP right now, and the beta blockers like propranolol, topiramate, which is anti-epileptic, and ACE inhibitors like candesartan. Coming to the second generation, flunarizine, amitriptyline, and sodium valproate. So this is one study which is published in American Headache Society. What they tell is the CGRP has become the initial mode of treatment and the first line of treatment, which is as efficacious as the existing therapies like beta blockers, topiramate, and candesartan. So the problem with existing treatment is all the drugs acts on the single aspect or the single target. Coming to the triptans, it acts on the blood vessels, NSAIDs on inflammation, ergotamines again on blood vessels, beta blockers acts on blood vessels. We can see most of the drugs acts on the blood vessels or the inflammation. So that's the problem, because the problem is so complex. So you cannot prevent the problem or cure the problem just attacking the single target. So that's the gaps in the existing treatment. Coming is the gaps. There will be a delay in the diagnosis, which will lead to chronic migraine. The patient will not go to work. Patient will lose the work, and they may lose the financial aspect also. And because of suboptimal treatment, the patient may go for chronic migraines, and which is very, very difficult to treat. Once the patient comes up with chronic migraine, it is very, very difficult to treat. The problem in the existing treatment is limited options like beta blockers, antidepressants, and anticonvulsants. So these drugs are not exclusively used for migraine. All these are used for BP, hypertension, and antidepressants. They have found after some time that it is effective in migraine prophylaxis. The problem with this existing treatment is it has a lot of side effects because of tolerability issues, and also efficacy is also a concern. And the problem with the CGRP is right now US FDA is approving a lot of CGRPs. The problem with this existing therapy is it is very, very expensive, very, very expensive, and it has to be covered by insurance. And the long-term safety concerns we don't know. And since it's a monoclonal antibody, the body itself can develop antibody against the antibody. And still, a lot of data needs to be come to the forum to establish the efficacy and safety. And usually the existing treatment followed is one size fits all. So that doesn't work in all the parameters. And existing insufficient focus on non-pharmacological treatment, because people directly go for NSAIDs. They don't follow the non-pharmacological treatment, which I just mentioned, like CBT, biofeedback, diet, exercise, and stress management. Limited long-term solutions will be there because of continuous use. Patient may get the tolerability issues and the efficacy concerns. And the habituation will be there because of using the same drug again and again. It may not be effective, which is nothing but habituation. So which this I will not go to this particular slide, which I think Dr. Srivastava will be touching upon. These are some of the guidelines. AHS guidelines has come, which I will not go through it. Usually, it has to be greater than 10 days in a month. Then only the patient has to go for a prophylaxis treatment. So these bodies have come up with various guidelines. And the goals of the existing migraine prophylaxis is to reduce the migraine days, to reduce the severity, to reduce the duration, and to reduce the existing treatment. So there has to be a lifestyle modification like magnesium, vitamins like riboflavin, coenzyme Q10. Obviously, a lot of data needs to be come to the market, but these are some of the things which are very much neglected. And the melatonin, because the lack of sleep is one of the triggering factor for migraine. So by giving melatonin, the patient will be having a good night's sleep, and the behavioral interventions can be done. So again, the contraindications of the existing prophylaxis treatment, just like topiramate, has a lot of problems like renal problems. You cannot give it for the long time. Sodium valproate, again, it causes liver toxicity. Antidepressants like amitriptyline causes cardiac problems like tachycardia and suicidal ideations. Propranolol, obviously, it causes bradycardia and asthma. So obviously, you cannot give this particular treatment for long duration. Candesartan, which is given for hypertension, it causes hyperkalemia. And botulinum toxin is again approved by US FDA. It has its own problems. So this is the timeline of the drugs of CGRPs. Usually, botulinum toxin came around 2010, wherein USFDA approved. 2018, again, USFDA started approving various CGRPs. So in the final slide, so you develop a bat-like abilities. You can sense the light, sound from the miles away. Unfortunately, it is not cool. So this is something superpower no one wishes to have. So after this, I think I'll hand over the platform to Abhinav. Oh, over to you, Abhinav.
Thank you, sir. Thank you so much for that detailed, wonderful session on migraine. I would request our next speaker, Dr. Ravi Srivastav from France, to kindly enlighten us with the technology behind this novel product mix spray. Thank you.
Thank you very much. Let me open the presentation. I hope it will work. Perfect. Can you see it? Hello?
Yes, sir, we can.
Sir, just if you can wait for 2 minutes. Yeah, the screen is visible. Screen is visible. Just 2 minutes.
Okay, very well. Thank you. Hmm? Oh,
Okay, can you see the slides of
yes.
the presentation? Yes?
Only 2 minutes. Depuis l'Inde, pousse tout le monde. Là, ça me fait pas comme lui. No.
Oh, there's a technical glitch. We are not able to add more than 100 participants, so we are sorting it out. Give us 2 minutes.
Okay, okay, take your time. Bon, c'est bon, je mets tout. Je vais laisser la première partie, je vais commencer plus tard.
Vous voulez que je réduise pour que vous puissiez voir le reste?
Oh oui. Can you see the slides?
Yes, sir, your slide is visible. Yes.
Okay, so I thank you, Dr. Shetty. He already gave you most of the details about migraine and CGRP and the currently available drugs. So let's come to the mixed spray, which is, I think, in the world, this is the first topical CGRP as well as pro-inflammatory cytokine trapping spray. Okay, this seems something new to you, but when I will explain to you what is happening, because this product was developed in collaboration with the European Migraine Research Center, we are happily located in the same city where we are. Vitro Bio is a partner of Hetero for research and development. And in France, we work in collaboration with other institutes like INSERM, which is the government R&D research throughout the France. Now, Vitro Bio, this company for research, we do only research and development, and it was started in 1995, and now we are doing research since last more than 25 years in the field of polymeric drugs. Dr. Shetty just now told you that okay, migraine is very important disease because it's affecting more than 20% population in the world, especially women. And here I see is the age group between 20 to 45 years. So if they have migraine, I think you have to ask them first why it is. Now, the physiopathology of migraine, as he was telling you just now,
Sir,
you know
Sorry to interrupt you. Can you do the slide presentation full screen?
Full screen. Wait a minute. Is
Yeah.
it okay now?
Now it's okay.
Okay, I'm on. Ah,
Yes. So we were there. So this is the trigeminal ganglion, which is located near the hypothalamus, and it is like a tree-like structure where you have the branches all over the body, but particularly, of course, it is in the brain, in the brain meninges, but also in the nasal cavity, in the eyes, oral cavity, including the intestine. So when this trigeminal nervous system is stimulated because of an external trigger, which may be completely different in different migraine cases, so it stimulates and activates these nerve endings which produce CGRP, it is calmodulin gene related protein. This is a cytokine, but at the same time, when it circulates into the blood and when it is also produced at the level of nasal mucosa, it starts, it produces other inflammatory mediators such as interleukin 6, interleukin 12, anti-NF alpha. So, you can understand that in a disease, it's not only one cytokine, it's not only one protein. There is one of the proteins is key protein. For example, when you have allergy, you can say, okay, histamine, everybody knows. But at the same time, there are other inflammatory proteins. So in the same way, for migraine now, since last about 10, 15 years, we understood that it is CGRP, it is important, but at the same time, there are other cytokines, inflammatory cytokines, which are also there, and these cytokines damage the nasal mucosa and cause and CGRP, it leads to vasodilatation, but there is also inflammation and damage of the nasal mucosa. Now, why? Why this newly discovered CGRP is becoming so important in migraine? You understand? Is okay? Hello?
Right, sir. Right, sir.
Yeah. Okay. CGRP is important because it was not known before. Because the triptans and all we were using to reduce the vasodilatation. We were trying to construct the vessels, but now we know that CGRP is causing vasodilation, and it is 10 times more vasodilated compared to prostaglandins, and even 100 to 1000 times greater vasodilator compared to acetylcholine. So all the efforts are now directed on CGRP, and as the CGRP is also produced at the level of nasal mucosa, everybody is concentrating on CGRP, but nobody is thinking about the state of nasal mucosa, because if you see nearly 60% of the patients having migraine, they also have nasal congestion. But okay, it was never treated. We never considered that as a part of migraine. So there is nasal inflammation. So what all the current treatment target is all concentrated on CGRP. Now, the Dr. Shetty already told you about development of CGRP treatments, which can block CGRP receptors or which can directly block CGRP in through intravenous way or by oral route with GPANs. But why now more and more research in most of the big pharmaceutical companies, it is directed to administer the CGRP blockers through nasal route. Why? Because as I told you, the nasal mucosa are extremely rich in CGRP receptors, and at the same time, when the lot of CGRP is circulating into the blood, because the CGRP levels are very high, not only during migraine attacks, but slightly before migraine attack and even in between the attacks. So the concentration of CGRP is high on the nasal mucosa, which so as it is high, so the aim is to neutralize it directly on the nasal surface or to block the nasal receptors because this may help easy administration, avoid side effects, and it may go faster. In our opinion, what could be the best treatment approach? First, okay, we need something which can remove CGRP. This is the main vasodilator protein continuously because it is not there, as I told you, at the time of migraine, but even before it. And at the same time, such a treatment should not interact with any other cells on the surface of the nose. That's what we wanted. That can be considered as a very good treatment because it is removing CGRP, but it has no effect on any other cells in the body, on any of the biological functions in the body. So it will not have any side effects. So what Vitrobio, before now nearly 15 years, we considered a strategy. We thought, why not to find something which we can apply on the nasal surface, which has no interactions with the nasal mucosa, so it is safe. At the same time, is capable to attract the CGRP as well as other inflammatory proteins which are present on the surface of the nose towards the field. So the advantage is we are anti-CGRP and even anti-interleukin 6, interleukin 12 and TNF alpha without having any interactions with the cells in the body. So our target was first find something, a spray, nasal spray, because that is the only way to introduce the medicine into the nose. So it should be film motion. We wanted that if it makes a film, that film should be stable for at least few hours, at least 4 to 6 hours, so that not to repeat the application all the time. Thirdly, we wanted the film to be strong to protect the nasal mucosa against migraine triggering factors. We wanted the film to be safe, not to have in contact with the nasal surface. Most important, we wanted to have a property in the film that it should attract, it should be osmotic. So if it is osmotic, we thought it will attract the liquid from the nasal mucosa which is already damaged. So at the same time, it will also attract all the free floating CGRP and other cytokines which are on the surface of the nose towards the film. But that is not sufficient because you may attract, but these proteins may liberate again and again enter into the body. So we wanted finally to trap these proteins, CGRP and others, into the film. So this was our research project. We started in about 2005. So what we did, the first step of our research was to find something, a liquid which is osmotic. So here you can see you have the nasal mucosa. If you put something, if it is osmotic, what it will do, it will attract the liquid from the nasal surface so as to clean the nasal mucosa. So we found something which is based on glycerol because glycerol is 18 times more osmotic than seawater. So you can understand that if you put seawater on the nasal surface, already it's irritating. So that is why we use a concentration between 1 and 2%, but not never more than 3%. But its stability is very less. If you use seawater, it's less. But this solution which we prepared, which is 18 times more osmotic than seawater, was very good. But it has some problems that its duration action was short. Why it was short? Because you are very osmotic, you attract a lot of liquid, but at the same time the liquid gets diluted and it was slightly irritant. Anyway, this discovery was the first which was patented in 2005 worldwide. Second thing we wanted now, okay, we found osmotic solution. We wanted to render it film motion. But the problem is how to render a solution of glycerol film motion. We thought if we can aid the polymers, because polymers they have different binding sites, they may be natural, they may be synthetic. So we thought if we can use specific polymers, so we screen thousands of polymeric molecules to see which one can bind with the glycerol. So you see here we have a polymer, and if it can bind with glycerol, it can convert the glycerol into a film. And if in that case, when you spray the product on the surface of the nose, immediately it forms a film which is osmotic and which is resistant to liquid flow. So this was the second discovery we made. But the problem still was that this film was not very absorbent. It was not collecting the proteins inside it. So we added some of the gelifying and thickening agents in the film in different proportions. And this work was completed in 2013, where we filed a patent in 2013 for a stable absorbent osmotic film which can be applied on the nasal surface. Now the problem is you can apply. When you apply, you can attract the CGRP as well as other proteins and you can keep the nasal surface clean. But the problem was these CGRP molecules and other proteins, they can, when the film is broken or even not, because these proteins are produced continuously. So we had to trap them. So the fourth step was that what we did, we said, okay, we have the polymers, they can block glycerol. For example, we have about 10 or 15 among 1000 we screen, but we can also try to find something, see the same type of polymer which can trap glycerol, but at the same time they have the capacity to trap specific proteins which we select. For example, CGRP. So we screened again many polymers and found those. You can see here. Here you have a polymer. It was capable to trap glycerol, but at the same time, we have the same polymer or another capable to trap CGRP, interleukin 6, interleukin 12, TNF alpha, or those proteins which we wanted to trap. So now, and this patent was filed only in 2020. It is worldwide, including all the countries in Africa, Asia, Europe, US, because now we have something in hand which can be applied on the surface of the nose, which forms a film. The film is osmotic, so that it can attract all the contaminants which are free floating on the surface of the nose, including CGRP and other proteins. It can trap the protein and it has no interactions with the cells, with the nasal mucosa, and it's not entering into the body. So it cannot have any side effects. So this was our research since last about 10-15 years. So here you can see the mode of action. Here is the film which is here. Now, this is the nasal mucosa. You have inflammation, inflammatory cells, CGRP, and other cytokines which are here. When you apply this osmotic film, it will attract, now the second slide on the right, it will attract osmotic liquid towards the film, and with that you can also attract all these cytokines which are present on the surface. When you do that, when the cytokines enter into the film, we trap them with specific polymers. And finally, when this film, when the nasal mucosa is clean, and we keep it clean all the time, and if there are no inflammatory proteins on the surface, the nasal inflammation reduces. And when it's clean, the cells start growing. When the cells grow, they within 48 hours, the nasal mucosa is totally recovered. When it is recovered, it doesn't allow the contaminants or it minimizes the migraine triggering factor entry into the body. So this was our aim in the beginning, and this product is now. So the mode of action I told you is the film. It can block CGRP other proteins. It's absorbent. It can not only bind but also neutralize these proteins as the way the different type of drugs which everybody is trying to search CGRP monoclonal antibodies which can bind the CGRP. We are doing the same. We are doing the same, but they are not monoclonal antibodies. It's only a film. We are just attracting them towards the film and blocking them there, and without any side effects. So this is the mode of action of mixed spray. Now, there is a lot of research work. So this product is now certified in Europe under new MDR regulations as a medical device. So it can be sold without medical prescription also. It's presented as a nasal spray 15 ml, which is sufficient for 2 to 3 weeks. Is particularly suggested for migraine prophylaxis because you cannot suggest such a product for migraine as a migraine instant acute treatment. Why not? Because okay, it will reduce the CGRP and all, but the CGRP which is circulating in the body remains there and vasodilation will be there. Our aim was not to treat at suddenly like a triptan and stop it, no, but to reduce the intensity of migraine progressively by recovering the nasal mucosa, reduce the frequency of migraine. So this was our aim. So it is more a prophylactic treatment which helps people because if you ask any patient having migraine what they want, they say okay, they may not be that interested to stop the migraine totally, but at least if they can get a relief, if the intensity is less, if the frequency is less, already they will feel much better. So this was our aim. So now we conducted some, okay, during the research we had some pharmacological tests. You can see on the left side, it is in the mouse. So what we do, we take the rat, we inject an inflammatory soup which causes strong inflammation in the brain. So here on the left side, the first one, when you inject, you see that the pain tolerance of the animal reduces within 2 hours. It is really defined lot of pain, and then progressively it reduces thereafter. But if you give four times 4 days, they were treated with mixed spray. So the controls, they still have the same curves, they still have a strong pain compared to the migraine rats. With the rats which were treated with mixed spray, you see the pain intensity was much less. Similarly, you can see the activity in the brain of the nociceptive neurons, means the neurons which transmit the pain. So here, if you give only saline, in the beginning they are not treated in this way, so there is no pain. But when you inject the inflammatory soup, immediately you see that there is strong pain. On the other hand, if you treat the rats with the mixed spray, and here when you inject the inflammatory soup, is same like this one, the pain is much less. So this proves that migraine, that big spray has some effect on the brain in such a way that it reduces pain. We conducted multiple clinical trials. This is a observational study which is done by the European Research Center in France. So now there are already, they tested the product on 322 migraine patients between 12 to 67-year-old. They just, it is not a real clinical trial, but observational. They want to see what are the effects in the migraine patients. And the patients which were selected, they are all according to the classification of migraine with respect to the criteria of International Headache Society. And you can see that the treatment, when you treat these patients for certain time compared to the patients which were not treated, we reduced the frequency of migraine from nearly 9 to 5 per month. The intensity, which was about 9, goes down to 6, 7. The duration of crisis also reduces. So the effect of all these improvements is that, there is a migraine impact test. So they see the effect on certain parameters like general pain, social relations, vitality, their so these parameters they improve a lot. Means the person feels much better with respect to the quality of life of the person when he's treated for mixed spray for certain time. Certain time, in my opinion, it's minimum 1 month, but you have to repeat, you have to continue, because unfortunately this is not a disease which you can cure. You have to continue the treatment as a preventive one. And if you use a preventive treatment, the most important part is you have to take it for a long time. And if you take it for a long time, it should not have any side effect. Because if, for example, propanolol, very good. I unfortunately, now I don't have migraine. But when I was young, up to the age of 30, 35, I had repeated migraine. When I had migraine, I went to my doctor and I asked him, what should I take? He suggested me to take beta blocker propanolol. Said, okay, why not? He said, okay, we'll try it for 6 months and we'll see whether you get relief. Okay, I had normal blood pressure, no problem. But I took it an anti-hypertensive means beta blocker for 6 months. After 6 months, there was not much improvement. So finally, we decided to stop. But when we stopped, the blood pressure went up. It was 14, 16. So when it was too high, he said, me, okay, in that case, you have to reduce it progressively. I did it for a year, but still the blood pressure was strong. Now I'm 67-year old, but still today, even after 25 years, I continue with propanolol, and I had no migraine because of the age. I think the frequency reduces considerably with the age. So these are the problems with a preventive drug if you take, because you may have side effects. So this was the first study which proves that my mixed spray is effective. One another study, it was done um, in the migraine patients according to International Headache Society criterion. There were 125 patients between 18 to 55-year old. We had 60 patients were treated with mixed spray and 59 with the placebo, which was saline solution through nasal route. We are giving them during 12 weeks. They receive 2 or 3 sprays of the mixed spray, 3 times per day. And here I show only the results of the headache impact test, which takes into consideration 6 parameters at a time on the headache, because we are not much space here. So you can see that compared to baseline means at the start of the study, after 3 months of treatment, you find the mean headache impact test parameters, there was is some reduction, because unfortunately, even with the CGRP antagonist and CGRP blockers, the effect is not that strong. There were no side effects except some dizziness, runny nose. Among 120 patients, there were 8 or 10, nausea, weakness, dizziness, but these effects are not directly related to the administration of mixed. On another study we did is a randomized double-blind clinical trial, because the question very often people ask whether it can be used in pregnant women and in children. Unfortunately, it's very difficult in Europe to claim that a product can be used in pregnant women or children. even if it is totally safe. But we conducted a trial, a small trial on 31 patients, where we had 16 children between the age of 3 and 18 years, and 16 pregnant women. So the mixed spray was given to 16 patients and the placebo to 15 for 90 days. Same regime, 2 or 3 sprays per day, 2 or 3 times per day. And you can see here the frequency of migraine attack after 1 month, after 2 months and 3 months reduces considerably. So this is the reference product, which was a placebo containing saline and a thickener, and the mixed spray. So after 1 month, the reduction is very less, but after 2 months and 3 months, you can see that the intensity frequency of migraine reduces considerably. Here you have the migraine disability assessment test. They also do to see, the general impact on the quality of life. So the grade of migraine intensity was measured. One is very less migraine, second is slightly intense, third is very intense, and fourth is very, very high. And you can see that there was no effect with the placebo. The seven which were in the class 3 intensity grade remains the same. And one it was in class 4, very strong, remains there. But in mixed spray, among 8 patients, all of them, two were in strong, they had migraine of grade 4 and 6 having the migraine of grade 3. All of them reduced to grade 2. This shows that mixed spray helps reducing the intensity, frequency, and duration of migraine if you take it for 2-3 months. But looking at the duration of migraine, which remains for years and years, 3 months is not much because it is tolerable. So now just the last diapositive where if you compare the effect of the use of mixed spray compared to other products which are available in the market, okay, it is this mixed spray is specific for migraine. This is a good prophylactic treatment like many others, we can say. It cannot be used much for crisis management, no. It acts on CGRP. There are very few products which act on CGRP because they are all symptomatic. It is a multi-target. Why? Because we are not only acting on CGRP, but also on other inflammatory proteins which are present on the surface of the nose, which continue damaging the nasal mucosa, and which continue, in that case, triggering migraine. So we are working as a global treatment, prophylactic. And currently, as I told you, this product is described, registered as medical device. It will be the same in all over the world. So it can be sold as a non-prescription drug. So thank you very much. As you can see, this is a totally new generation of migraine prevention treatment. You can also ask the question why it is not known everywhere in the world, because it is new. It is new. We launched it only last year, in fact. And second, it's not a drug. When it is a drug, we can prescribe it. But for us, it's difficult to register the product as a drug. Thank you very much for your attention. We'll come back to the question and answer session.
Thank you so much, Dr. Ravi, Dr. Adarsh. Thank you so much for giving us your valuable time. And I believe that mixed spray is a novice concept, which actually we needed your detailed presentation, and I'll say lecture on the technology and how it works, highlighting about the clinical studies. Obviously, for all of us, if you have substantial clinical studies on any brand, it actually augments our confidence on that brand. I'll just briefly share it again with all our attendees. It's the first preventive treatment. Mixspray is the first preventive treatment of migraine in Kenya, a novice concept, a clinically proven brand for the preventive management of migraine. So you can take it along with your acute therapy. Whenever your patient has an attack, they can take their acute therapy and they can continue Mixspray. So the technology is a patented technology called filmogenic glycerol polymer in Mixspray. It actually, this technology in Mixspray forms a protective layer in the nasal mucosa, which is actually considered as a barrier which prevents those chemical trigger substance which increase the level of a protein, a neuropeptide called as CGRP in the bloodstream. And this CGRP is basically responsible to produce certain inflammatory mediators which triggers migraine. Now, Mixspray forms a protective layer in the nasal mucosa, thereby preventing the entry of these chemical substance. And also because of its osmotic action, it actually absorbs all the CGRP and inflammatory mediators from the bloodstream back, and thereby it reduces the level of these neuropeptide and inflammatory molecules, which causes migraine. And that's how Mixspray reduces both intensity and frequency of pain. Clinical studies have been shown by Dr. Ravi. And also, I would like to thank Dr. Adarsh for, in a detailed way, he explained us about migraine, the current treatment available in migraine. Thank you so much, sir. I've requested participants, if they have any questions, you can type it. You can ask both our speakers those questions. So there's a question which I can see. It's for Dr. Adarsh. If you can briefly explain us about CGRP, sir, and how important is the role of CGRP in migraine? Yeah.
Yeah, am I audible?
Yes, sir, you're audible.
Yeah. The previous CGRP is a recently developed concept. Right now, if you see the US FDA, now they have started approving all the products like monoclonal antibodies of which targets the CGRP. So this is very, very novel concept. And I think the recent guidelines, which I just mentioned on the American Academy of Headache, and initially CGRP was at the third line treatment. So after getting all the evidences, it has moved to the first line of treatment. I think this is published in February of this year, and they have moved the CGRP as a first line of treatment, and they have got a lot of evidences that CGRP blocking prevents the frequency and intensity of headache. The only problem with the CGRP is the cost, and it is has to be given by injection.
Yeah, and it's not available across the globe. It's not available in every country. Right? So availability again becomes an issue. True, sir. Another question which we have is for Dr. Ravi. The question is that Mixspray is a preventive treatment for migraine. So how long a patient should take it? And like how much time does it take to the patient to realize that, yes, there is reduction in intensity and frequency?
I think, but normally patients should take it for at least 2-3 months first.
Okay.
And secondly, he will have to take it throughout his life up to the time he is subjected to migraine.
Right.
Unfortunately, it is migraine has no, even with CGRP or any other drug, there is no treatment which can cure it. So they should take it and repeat it whenever they find that the intensity of migraine is increasing. So they may take it for 3 months, stop for some time, and when they see it started again, the intensity is going up again, they can take it. And taking into consideration the cost of Mixspray, compared to CGRP inhibitors or receptor blockers. In France, the cost of CGRP treatment per month is about 700 to 1,000 US dollars per month, and it is not reimbursed by Social Security because it is too expensive. So I think Mixpay can help a lot.
So they want to know what is the role of Gabex in treatment of migraines.
Gammas are there, but these are the old treatments because everybody was trying to do something. So they were using everything they could, like triptans. We believed in triptans for a long time. They just tried to, but vessels are dilated, so they want to reduce it. Okay, now we tried antiepileptics, antidepressant, GABA receptor blockers, and all that. But the problem with all that is they are not specific for migraine. They may work in some patients to some extent.
Difference between migraine and tension headache more explicitly.
As Dr. Shetty told you just now, he can explain it much better. Migraine has its specific symptoms. Unilateral pulsating, photophobia, vomiting, and tension. Dr. Shetty, how you can differentiate between the two?
The migraine is usually, it is more common in females and it is unilateral. It can be bilateral in very rare cases, and the severity of the pain is moderate to severe. And there is a diagnostic criteria which has come up with the society, which tells the pain has to be there for 4 to 72 hours.
Yeah.
And it has to be preceded by nausea and vomiting, and there has to be a sensitivity to light, smell, or the aura. So that's about the migraine. If you want the another one is the cluster headache, right?
Yeah, tension
Cluster
headache. He was asking
tension.
tension headache specifically.
Yeah, tension is usually bilateral. If the headache is on the either side of the head, then obviously you can rule out migraine. And it is mostly bilateral, and the pain can last up to 1 week. That is
Yeah.
very long
Yeah.
duration. Yeah.
Thank you.
Thank you so much, sir. I think we don't have any other question. I think most of the queries have been sorted out. But if in case we have questions when we are in the field, we are going to, if we are not able to answer, we are going to come back to both of you to get the correct answers for related with mix spray. I would like to thank all the participants for giving us the available time. And I believe this session was very informative. We learned a lot about migraine, the various treatments associated with migraine. And I would like to thank both of our speakers for giving us the available time and taking us through the product, Mix Spray, a very novel, novice, innovative product, and the first treatment of migraine in Kenya and across the globe. Thank you so much, everyone.
Best of luck to all of you.
Thank you, sir.
Thank you, everyone.
Thank you, Dr.
Thank you,
Adarsh.
Abhinav.
Thank you, sir.
Thank you.
Thank you, Abhinav. Thank you, Dr. Ravi, and thank you, Kenyan Association.